Good morning all. Morning colleagues to this public meeting of the Board of Directors. Particular welcome, we've got one of the public governors, Robert Dixon, observing on the back. A warm welcome to you, Robert. And we have at least one member of the public online. Welcome, Kath, online to observe. I'm perfectly very much encouraged. Go, good to see your face for a moment, Kath. Is it Kat? Kat, I should say. Okay, but welcome to you also, Kat. I do welcome the prospect of wider numbers of public observing the public board. It just feels to me a good thing for us to be moving towards. So, welcome to you all. We've got one of those agendas where if you just read the papers and think, oh, there's so many decisions for us to get through, and that's right. At the same time, almost all these papers have had a preliminary chew-through in at least one of the committees. So in many cases, we will be seeing papers where a lot of the seriously hard work has already been done. Can I check, first of all, if there's going to be any matters of any other business coming up that I don't yet know about? No, that's good. So we can just go straight into the agenda. We've got the minutes of the last meeting, which was the first one that I was unable to attend. So thank you, Ruth, for your sharing of it. Not for me then to say whether these are accurate minutes, but they normally are. Anybody got any corrections to suggest? No? Oh yes, Ruth.
One point that Alistair's point about pain control in ED, I think we followed that up with some questions, don't you think it was it wasn't on any action.
Okay, so can we amend the minutes to Thursday?
Not the minute, I think it's just an action or a follow-up.
Oh, okay. Alistair, you're nodding your head. I'm not sure what the follow-up is expected.
I think we were going to try and target more of Joe's questions.
Can you turn on your mic?
Sorry. We were going to target Joe's questions more to pain follow-ups. It was whether it was acute pain or whether it was a chronic pain question.
It was to make sure we delineated between people who had acute pain, where we absolutely do need to sort it, as opposed to people turning up with chronic pain, where ED may not be the most appropriate place to have it resolved, and so that we had a sensitive measure to try and delineate between both.
Okay, so Joe, are we addressing that in the format of the questions?
I would say no, but I think we have got the option to be able to do that because of the methodology that we use within the real time. So I'll have a chat with Sam and the team and look at how we may develop some questions that allows us to delineate that. So apologies on my part, I've forgotten that.
Okay, thank you. That's a particularly effective follow-up then. All content with that? We kind of know that pain management tends to be the second of the highest issue that people are not always entirely happy about. So good to enable us to drill further into it. Any more matters directly from the minutes? Then in the action log, I think the only substantial issue was about the teardrop garden, and we've got a really full report back. So from those that raised it, and I can't remember who did, are you content with it? Should I be looking at it with you, Steve?
It was a walkabout.
It was a walkabout.
That's right, it was a walkabout, and yes, and Damon alluded to such things in the governor's meeting last night.
Good, okay, so you're content with the actions been followed through as appropriate. That's great, thank you very much indeed. In which case, we're into my introduction, and I've only got two things to say. First of all, I'm really looking forward to this evening. I'm going to St James's Park, but not to watch the football, and that's the good thing about it. Sorry, we're celebrating 20 years of volunteers service this evening, and a celebration event, and it's just a great opportunity for us to be collectively recognising the role that volunteers play within our organisation. So that's my main point. And my second one is just to say I'm feeling in September mode. You know, we're into this sense of got through the summer, how delightful, restful it all was for us all, wasn't it? Yeah. But certainly this is now the period for forward planning and thinking big, and there's lots of big ideas floating around, and it's an exciting time to be in the Trust. And that was all I wanted to say by way of my intro before I hand over to Bijou with your dashboard.
Yeah, so this is the dashboard that covers August and September to date. I think following on from Paul's view there of, we have, I think very much, you can see by the rain outside, left the summer behind us well and truly. However, on the back of that, we have been and seen a very positive improvement trajectory around all of our performance metrics, so in particular around the ED standard, diagnostics, and our cancer faster, 28-day faster diagnosis. These are all measures that we have been trying to improve on and have been shown steady improvement. I think it was really good to see our position in August around what they looked like. And I think we shared that at Governors in terms of a most up-to-date position yesterday evening. Similarly, a really strong financial position, and just to pull out in terms of our workforce, our lowest sickness absence rate for some time in August as well. I think in terms of some of our strategic updates, the Berwick build continues on track, and we've managed to do some really good estate changes at Blythe, again making both our ward environment much more suitable. We've seen a big programme of work across North Tyneside on one spec to upgrade our wards. Blythe now been upgraded, and the top floor of Blythe will also come to fruition for our new children's unit up there, which is predominantly around outpatients. We've also had a lot of work going on through the summer around alliance working, and those work streams are still are working their way through particular patient pathways. That's an ongoing piece of work, and I think as relationships start to develop further across, in particular across ourselves, Newcastle and Gateshead, I think we'll start to see some speed and some real clear, true deliverables in terms of improvements for our patients. The one thing to note on there as well, you'll see that we have changed our, calling it the Cramlington front door changes. So we've had streaming at the front door to ensure that we get our patients, the right people, right place, right time. And this just enhances what the changes we've put in place enhances this further, so we have a much stronger senior presence right at the very front of the door when somebody walks in, to either navigate them into the ED department, which is where it's most appropriate if they're in emergency, or to one of our other sites for our urgent treatment centres, ambulatory care, or to our elderly assessment centre. So it's early days, but so far we're measuring both from a performance point of view, but also a patient feedback point of view, and so far it's shown some very promising results. So obviously we'll keep all updated on that as it develops further.
Very good. Any questions or comments? Much as this, many of these points can appear later on in other papers, but any questions or comments? In which case, let's move into the first of our two performance items, and it's a chance actually to drill down into a little bit of that data as well, particularly around cancer. But I know Rahul and Beth are going to speak a little bit more widely as a part of the business unit update on clinical support on cancer services.
So first of all, thank you everybody for inviting us to speak today. My name is Dr. Rahul Dharmadhikari. I am a consultant radiologist and business unit director for clinical support and cancer. My colleague Beth Goodwin with me, and she is the deputy director for clinical support and cancer. We provide a myriad of services to the trust and to our patients. And the way we like to look at ourselves is, while our primary responsibility is to our patients, we also help our clinical colleagues do their job better. So there are various services that we provide. We provide radiology services, which includes various diagnostic modalities. We also provide pathology services, which include chemistry, toxicology, microbiology, histopathology. We are responsible for cancer targets. We provide pharmacy services. We are also responsible for infection control within the trust, and we also take care of the medical examiner's office. So I'll just kind of drill down into each of these specialties a little bit, and then at the end we'll be happy to take any questions. So starting with radiology, it's a very important service in the sense that there are a lot of patients on which you cannot take any decisions without diagnostic services, and that is borne by the fact that within the last 2 years we have seen a 13% increase in demand for our services. You can imagine that that is a difficult demand to cope with, but so far we have been managing to cope. Demand is seen across all the services we provide, so be it ultrasound or CT or MRI. We continue to deliver a very high quality service. We meet all national reporting standards. In fact, we have internal targets which are much more tight than what is mandated nationally, and we managed to meet these targets. Now we do take help from external agencies to meet that demand, and the ambition is obviously to grow and recruit our own, and over time hopefully not require any external help. We've managed to we've achieved a lot in the last couple of years. So we moved to allowing patients to self-book appointments for X-rays based on the convenient time for them. This is done online. The idea is to kind of increase that from X-rays to other modalities. We started a post-mortem CT service. We are using artificial intelligence, and we have deployed that to report chest X-rays. We also got mandated to do something called targeted lung health checks, which is basically a surveillance program for lung cancers, which will help us capture these cancers early and reduce deaths. I mean, it is known that if we capture lung cancers at stage 1 or stage 2 instead of stage 3 or stage 4, we can reduce deaths by about 30 to 40%. We have been quite successful in recruiting radiologists in the last year or so, which was something of a challenge for us over the years. So we've managed to recruit 5 radiologists in the last 1 year, and they will start. They'll start with us in the next few months, and I think that will be a big help for all of us. We have also recruited radiographers both locally and from overseas. Go to the next slide. So pathology, again, a very challenging discipline. We do struggle to meet our turnaround times, but we do manage to meet them again with help from outside providers, and the ambition is to not need that help. We have worked in growing our internal workforce, and we have worked on skill mix where non-doctors are allowed to do a few things which they were not previously allowed to. We have also worked on staff morale. We are aware that the recent staff surveys show that the staff morale, especially in pathology, is slightly less than the trust average, and we are acutely aware of it. We're conscious of it. We kind of know the reasons for it, and we are working with our teams to try and improve that. Again, we have a few achievements that we can highlight in pathology. So we meet all the ISO standards and all the national scrutiny that we've been subjected to. We've always come out with flying colors. We have put in a lot of capital investment. Despite the heavy workload and workforce challenges, we meet our targets and provide a good sustainable service. We have just put in a new ICE and WinPath system to improve our services and efficiency. Going on to cancer and oncology, so we put in a lot of work in developing alternative workforce and increasing what non-doctors can do. So, for example, we are working on non-medical prescribers for oncology drugs. We have put pharmacists in the oncology day unit to administer chemotherapy. We are constantly reviewing our acute oncology services to try and improve the offering that we have. We have opened a new oncology day unit at Hexham. We are doing quite well with the 28-day faster diagnosis. We have struggled with the 62-day targets. Again, it's better than it was, but it is not where we want to be. It is regionally we are still better than most other people, but that is not our ambition. So some of that problem is because we have a lot of shared services with Newcastle on a hub and spoke model, and to some extent we have limited control over how we can deliver those services. But the important thing that I would kind of stress is that we are aware of it, we are conscious of it, and we are constantly working to try and improve what happens. We are also closely linked with the Macmillan team to get funding and other things to provide services. Pharmacy is again a big part of the service we provide. So we have opened a new pharmacy production unit. We will be mixing drugs for the whole of the region, and that funding has been signed off by the NHSE, and we will start delivering that service in early 2026. Again, we have extended the role of pharmacists and what they can do. A lot of our pharmacists to work on the wards to help with the nursing teams and share their workload. We are providing services to the virtual wards. We also provide community services through our pharmacy. And a recent problem which we hadn't experienced before the pandemic was drug shortages. We've so far been able to kind of provide alternative drugs and circumvent things to keep services going. Infection control is another big service we provide. As you can imagine, this service was extremely busy during COVID times. There are a lot of innovations that the team is doing. So, for example, if we look at the Clostridium difficile targets, we were slightly above target last year. A lot of work was put into education and awareness, and we are now slightly below target. So there's been improvement there. A lot of other infections we are working on to try and improve, outcomes.
And we're looking at the infection control annual report
Yes.
in later.
Yes. And then they have put in a lot of effort to kind of try and use non-disposable articles where safely possible instead of disposable things. We worked on a project to try and reduce the gloves that are used to avoid waste. Looking at our people, again, as I said, we are aware that we are slightly below the trust standard when it comes to staff satisfaction. We are constantly looking to recruit people to provide the increasing demand that our services are under. We constantly look at developing alternative pathways and upskilling rest of the staff, non-medical staff, because we do realize that, especially looking at the demography of Northumberland over the next few years, we will have to do things differently if we have to keep on providing the quality and quantity of services that we need to provide. That slide just kind of underscores the fact that we are slightly above the standards when it comes to staff satisfaction and happiness. So our 3 priorities for the next year is going to be working on this staff experience and improving staff experience outcomes. A lot of digital transformation is going on in all our services. We are a very digital IT heavy service. We use a lot of technology. And especially in radiology and certain other fields, I think artificial intelligence is going to play a very big role in the next 10 years, and we are aware of it, and we want to be ahead of the curve. So we are working on several projects to try and make that work for us. We are at the back end of the LIMS and ICE upgrade. This is a technology which was there for a long time and just replaced last year. It was a difficult change. We had some teething trouble. But we feel that we are now at the back end of that, and we will start realizing gains soon. We have an ongoing capital replacement program, and I cannot thank the trust enough for the support that we receive for capital replacement. I know that that is not the case up and down the country, and we are grateful for the support that we receive. We want to improve our cancer performance, particularly 62 days. The other big project that we have started over the last year or so is to reduce health inequality. So there is an increasing realization that when patients come from underprivileged areas, they are more likely to have DNAs, they are less likely to seek medical help, and we are trying to work on this to try and reduce this. And then there are certain other projects which we are looking at, like looking at polypharmacy and reducing the number of drugs that a patient requires by scrutinizing what they're taking. So there are a lot of initiatives which we are working on to try and improve the services we provide. So that is a very
Thank you, Michael. That's excellent. Beth, anything you want to add?
No, not particularly. I think the kind of key things for us for the next year really is, like Rahul said, staff experience. I can't underestimate that enough. Cancer and just keeping up with the kind of increase in diagnostic workload. But that would be everything for me.
Outstanding report and really good pulling out the significant achievements, but the thing I always do appreciate is you haven't sought to hide the areas of challenge that you've still got. So I've got a few questions, so I've got to sit on my hands and see who comes from the board. Richard, and then Bailey.
So first of all, thank you for a very good presentation. Through Family Connections, I've first-hand experience of many of your teams over the last year and a half, and I know how good they are. And yeah, absolutely outstanding service that we've received. I just wanted to pick up a little bit more on the staff experience piece. The detailed slides that were in the agenda pack were quite interesting, that you've got teams within there, and I know there's a risk on small numbers, that were achieving 90+% satisfaction results, and then some teams at the other end which were very significantly below the trust average. So clearly it's not one size fits all for staff experience within the team. I'm interested in a little bit more insight on particularly why the good are so good, and then what you're going to do about the ones that are less good.
So to start with, we've got lots of work going on within clinical support cancer services, and Jo's nodding because she's supporting us a lot. I think, interestingly, if you look at that table that we provided, I think we are very, we recognise that some of the patient-facing services are higher in the table than some of our more background services, like the laboratories and things, and I think that drives quite a lot of kind of value from staff, and we've talked a lot with the teams around how we can open the doors to some of those kind of background services a little bit more, with some open days and things, just to kind of share their excellence as well, and widen it out to the organisation. I think sometimes they feel a little bit forgotten, whilst they're not, but sometimes they can feel that way, and I think that drives some of the experience. Also, we can't underestimate the impact that the change in wind path and ice has had on particularly laboratory services, but also radiology.
Can we reflect on that in the next board walkabouts? Can we see if we can particularly focus on some of the backroom services that are feeling a bit less loved?
I think that would be very helpful.
Yeah.
And I think the staff experience is partially colored this year by LIMS, because I would not underestimate and say it was a difficult transition, and it took a lot out of the staff.
Bernie, I kind of bet that your question's partly been answered.
It certainly has been answered, the first part of the question, so thank you for that, and maybe through the People and Culture Committee we can have a little bit deeper dive into some of those things. That would be really helpful. Just it was really a bit of recognition, Chair, because radiology in particular, I think histopathology, has been a real recruitment challenge for the team in the business unit. There's been a amount of great work through Rahul and Beth and colleagues, so they're just about to get some really additional capacity there. So that's not what we want to create, that's been a huge effort to get there. So just a really good recognition, Chair, to say thank you and well done.
Very good. So we've got Jo, and then I think I saw Jo.
It's just a comment really, it's just to echo what Beth said in terms of assurance for the board. The work that the laboratories in particular are doing with my team it's very in-depth, and it's long, we recognise it's long-term doing this work, so there's a staged approach to the Working with Teams programme that Lainey and the team are leading, so I just wanted to give the board assurance that there was a lot of work being done.
Thank you, that's good to hear. Joan.
So I just wanted to have a go at saying how important the diagnostic services are for us as an organisation. We rightly celebrate our good performance in terms of referral to treatment and ED, but that is underpinned by an enormous diagnostic workload that has. We had a question at Governors last night, and I fell off my chair when we repeated the statement that Newcastle hadn't got enough radiologists. I mean, our radiology and diagnostic services are the very definition of excellence. They maintain all of their lab standards and accreditation, which is no mean feat. If you ever go and ask them a governance question about what they do, they have the answer there and then. But the turnaround times that we achieve, in particular with the staff that we have, are nothing beyond incredible, and is an underpinning block of the transformation that we've undertaken in that building. Has been celebrated. It's been celebrated for so long, I think we've forgotten what we've achieved. And we've done that really on what would be described in Newcastle definitely as a skeleton workforce. So big congratulations to Chief. They're really keen to what we do.
Chris, and then
just interested to pick up on the subsidiary cancer performance. Whilst it's relatively strong across the region, there's other pockets of the country that do achieve that 85%. So just interested in kind of getting your views and what actions we're taking to get us over that 85% line consistently.
Yeah, so there's, I guess, for us, focus work in particular pathways, and you'll have heard many times around one's particular for us is urology and colorectal that we need to focus on, but also it's just a real keen focus across all of the pathways, to be honest, and ensuring that we really drill down into PTL and bringing patients forward and not accepting people to be waiting too long, and real focus on PTL validation, governance and things. But then there's key bits of improvement work, particularly in urology, for example, in which they've changed the front end of their pathway, and the team are doing a really good job. At the moment it's in pilot phase, but it's around having an initial conversation with patients that kind of maps out what their journey might look like. Which sounds quite obvious, but also it kind of reduces some of the contacts in between and kind of smooths that and streamlines that pathway out. Some of the early feedback is really positive on that, so I'm just hoping that we kind of continue.
Great, Marion.
Thank you very much for the presentation. So just 3 quick things. With the new oncology unit opening at Hexham.
Can you turn on the mic?
Just
lean into it.
With the new oncology unit opening at Hexham, it's just about what appetite have we got with flexible working, but flexibility for the patients, about 7-day working across the sites, and that's a training issue and a recruitment issue. I think you do a great job regarding reporting radiographers and things like that. What can we do and what can I do in my role with the HP side of things to make sure we've got these people up to their optimum level so that they can help you in everything? And I was at Leeds yesterday meeting the new chief nurse, Duncan Burton, and this was very much a focus for him. And also how we get into schools and colleges to have that showcase. I think you're absolutely right for that, because if you think about it, in days gone by, the laboratory were always the ones, in Beja and I's day, they were always the ones to get all the training through at an early stage, and we had like 6, 7 and 8-year-olds coming into the lab, and we have got some of these people working there today, so it's just to keep that going, and I think we should showcase that.
So Marion, about 7 days working in oncology, that's an ambition. We are working towards it. We have put in investment into recruiting more oncology nurses. We are liaising with the oncologists in Newcastle to try and make more time available for us. They have promised us that there are people in the path, on the pathway, and in the next year or two, they would have enough oncologists to support the services that we want them to provide. About radiographers, I think for the first time in many years, our recruitment is almost full, which is amazing, and long may it continue. That will also allow us to upskill more radiographers, because a problem that we had up to now is because we didn't have enough. If we wanted to upskill some, then the base radiography work would suffer. So I think we would look at that in the next few years as well.
Yeah, no, I would just echo that. I think we had a radiology Leeds away day this week actually, and one of the big things was our kind of workforce, but also just kind of how do we the kind of career pathways for the future and retention, and it was a big thing we wanted to look at kind of strategy, and the team were really engaged in that. So thank you.
Alison, and then I'm going to move this on.
So, my comment is really good, but it is just, I suppose, there's a real underestimated how important it is to have the expertise in-house. If we look at radiology, microbiology, it's easy to say you could just use that, outsource it. Everybody you talk to trusts the internal reports because they're at a higher standard than outsourced. Reducing those will be fantastic as we've got more consultants in post. But I think there's also some learning for board that actually simply looking at moving bits of results or imaging around doesn't necessarily give the clinical results that doing it in-house is, and I see this as really welcome to the cancer team. They trust our internal reports because they're at a higher quality than those that are outsourced, and I think this idea that you can just outsource things, we need to always challenge, because I don't think it's borne out by any of the evidence, and I think that's a big learning point.
That's a really interesting point that we might want to reflect on more broadly in another setting, but thank you for bringing it up. I'm going to move us on. It was a terrific report. We've heard really positive direct feedback, which incidentally I can underline as well from family experience. We focused quite a bit on the staff experience, recognising that there are some areas where it's still tricky. We're going to look to get one or two board walkabouts to cover some of those areas, and P&C, People and Culture, is going to dig a little bit further into those areas that are problematic. We've heard plaudit for the radiology service, and that's just great to hear, lovely to hear that. We've heard on the focus on Cancer 62-day waiting list. It's been a frustration for the board for some time, not the frustration with our colleagues, recognising they are trying and we're all trying very hard, but recognising some of the barriers are really quite hard for us to overcome. We're going to just need to keep our sights on that. I know you and your colleagues are. Interesting possibilities around the 7-day working. It'd be really good to hear more of that, and that interesting challenge at the end around in-house, which I think has wider implications. Really good session. I may be right in saying maybe the last time, Beth, we'll see you for a bit, because Beth is going off on maternity leave shortly. And
Jeremy looks shocked.
You're no rush. Not quite yet, but from the board's point of view, it might be your last attendance for a bit, and we will just be awaiting your return with bated breath. Thank you very much indeed.
Thank you.
Let's move straight on to planning for winter. It feels like winter's here just today. I must say, when we got up this morning, it felt like we were in winter. But who have we got? Simon and Marcus are going to talk us through the planning, of which there's been a lot. And a reminder for colleagues, this is an area where we've chewed over it within safety and quality, and also within finance and performance. So I will invite the chairs of those two committees to just say if there are any highlights that came out of that the board needs to be extra aware of. But we have chewed into some of the detail quite a bit at board at committee level. Over to you. Simon, you kick off?
Yes, no, thank you. So I'm going to present the winter plan. I know there's more detail in the packs, and the first thing to say is that we've got, in addition to this part of the plan, we've got some additional work we're doing from a sort of longer term point of view. So one is around increasing bed capacity with the new ward opening shortly in North Tyneside, along with new front door model at NSEC, and also a lot of focus around some quality improvement work around the flow. We've set up a flow improvement group, particularly looking at the various processes on the ward to make them as efficient as possible, preparing us as we go into the next few months and beyond. So in terms of from a medicine emergency care point of view, so again these sort of 5 sort of key principles, which again a bit more detail within the packs, but I think particularly focus on that staff well-being and the patient safety and risk management, how we're using the bed stock, and really key maintaining that sort of elective non-elective streams throughout, and maintain that financial diligence by the way we're using some additional staff that we've got. So in terms of a little bit more detail, so as I mentioned, we'll be opening shortly some 27 additional beds at North Tyneside Hospital, and which will make a big difference in terms of our flow within the system. There are plans for a winter escalation ward. Now, this will be very much sort of a last resort, if you like, and we'll try and hold on there as long as we can, but based on previous experience, we would anticipate we may need some additional capacity around that post-Christmas period. And we've identified Wansbeck at Ward 8 and working very closely with partners in the organisation around that, which Marcus is going to sort of come on to as well. But we're sort of planning the staffing models around that, but that's what we anticipate we may need. But again, we'll try and hold on there as long as we can. Thinking about NSEC, so that the previously known as discharge lounge, now the discharge and transfer unit, so that's in operation 24/7. And there's also potential additional capacity in the procedures unit at NSEC, but again, we will be trying to avoid using that where we can. So what we want to do is maintain the unit's elective activity. Other things we're looking at, so some additional support from some of the pharmacy teams. We're having a conversation particularly around that busy period around January and February, increase the EOS capacity, working with NPC around looking at the staffing at the UTCs again in those January-February period, and ongoing work with the ICB in applying for the delayed transfers of care. So again, a lot of this has been mentioned previously about sort of learning from the kind of some of the learning from last year and previous years, and we're putting this in place for this plan. In terms of monitoring, so we are aiming, so particularly thinking around corridor care or temporary escalation areas, aiming for that to be zero both within the emergency department and on the wards, and also we're aiming to not have to use escalations at width of the plan. That's what we're aspiring to. And again, looking at the various different aspects there in terms of the modelling, the monitoring, sorry, that you can see there. So a lot of detailed focus on those different areas. Hand over to Marcus, I think.
Thanks, Simon. I'm just going to touch on some of the other business units, just to recognise that this is absolutely a group effort, the winter plan. And some of the things that Simon's alluded to there, for instance, opening Ward 8 at Wansbeck, it's just to reflect back to the board that the input from NHFM, from domestics point of view, from Portland point of view, the collective service support, and that's really critical to this. Corporate services, in terms of the support we get from the wider nursing team to make sure these things happen at short notice is really, really invaluable. And the support from the clinical support business unit as well, again, is key, particularly in ED when we really are busy and running at pace. From a community services point of view, really crucial and critical. We'll continue to work together on that. The immediate care beds will be key moving into winter, and we've got a good stock there that we can use across North Tyneside and the Wansbeck sites. There's a whole raft of innovations going on from the community in terms of the development of expanded virtual wards. Again, our priority and from an acute perspective is to try and keep people at home. So plans from community should hopefully significantly help that going into winter. And from a surgery point of view, continue to work really closely on the NSEC site. The developments of the front door, again, are a key part of the strategy Simon's alluded to, and the continuing support in terms of SDEC and making sure that the right patients are going through there, making sure we keep that sufficiently running in terms of all planned work, and just make sure we get that balance right to make sure that can continue to stream for every day to support AD in the NSEC site. From a trauma and orthopaedics point of view, the elements that Simon's talked through in terms of the additional ward capacity will significantly aid, and that will allow on Ward 7, something historically medicine have used, some additional bed capacity in Ward 7 down in North Tyneside for team to escalate into. Surgery will continue to do some red and green days. We're part of, Simon's alluded to it, the FIG on the NSEC side to look at how to improve and make sure the discharges are timely. We're getting people off the site as quickly as possible, so that work's continuing. And in terms of theatres, the board will be aware with developments in Hexham coming online that there's lots of ongoing work in place to make sure we're fully staffed, we're up to speed and we're resilient going through. From a child health point of view, we monitor this very closely. We know once PED starts to hot up, we know that adults are closely following afterwards. But there's a whole, again, a very much community-focused view from Child Health, which is really helpful and welcome, but also the development of having a direct line into the PEDS consultant, I think is a specific innovation that's really promising, and that will give alternative pathways and destinations as opposed to coming directly into the ED and NSEC for PEDS. And we'll continue to work on the front door streaming alongside UTCs to see if we can stream minor injuries again from NSEC directly down to the relevant sites in terms of UTCs. Okay. Any questions?
Marcus, Simon, thank you very much indeed. Can I just start with the chairs of Safety and Quality and Finance and Performance for any key issues that came up in their discussions of this? Alan?
No, from a safety and quality point of view, I think we're quite comfortable that the mechanisms are in place to provide good quality and safe care and to monitor that. I think the developments in PSERT in particular make it easier for us to be able to look at things when things go wrong. So I think we're doing the right things. I already asked a question around the paediatric bit, particularly the necessity for us to link with the Great North Children's Hospital, because there have been problems there. I understand discussions have been in place between us and the paediatricians up there, and they're now going to have at least two designated HDU beds for children, which is very good. It's a real risk area that we can't deal with HDU children here.
HDU, high dependency.
High dependency. Those children that are really quite sick, but not desperately sick. Well, they are desperately sick, but they're not needing intensive care. So, no, I mean, I'm comfortable. Things are.
Did you want to say anything further about the Newcastle?
Yeah, just in addition to that, Newcastle have managed to recruit quite a lot of paediatric nurses. So they were carrying a large number of vacancies this time last year. They've also managed to recruit and fill most of those vacancies. And I think that will also help in terms of there's two designated high dependency beds, but just the fact that they've got more staff on their general wards will mean that their flex that they have, which they haven't been able to do previously, I think will be better this year. I think also the work where we've got teams across Newcastle Gateshead, Cumbria and ourselves together, just from a kind of a clinical understanding, and they've had visits to each other's sites and understanding kind of what can and can't be done in terms of estate facilities as well has been really helpful, just in terms of being able to pick up the phone and have those conversations, which I suspect historically have been slightly challenging.
Yes, one of the areas where alliance work is starting to bring forward dividends, even if some of them is not yet easily measured, but some are.
I mean, there's also the potential that we've got new vaccines on the product, particularly the RSV vaccine. That should cut down the number of children coming in, but they're also vaccinating, as I said the other day, the elderly, if you're over 75, you're on an RSV vaccine.
Very good.
70 to 74.
Correct.
Okay. Phil, anything came up particularly from FIP?
No, I think we had a very good and comprehensive discussion at FIP going through the plan. I think we felt assured that we feel to be in a good place. It's good to see we continue to learn from previous years and so forth, and we'll build that into the plan to make it as resilient as we can. I think one of the things that strikes me is this is about the trust. It's not just the frontline impact, it's about all the support as well, and that comes through loud and clear in the plan. I guess the only other thing I would mention is that we did approve the capital spend for the North Tyneside provision on the 24 beds, so that should be in place fairly soon.
Very good.
Yeah, just a couple of quick things. So just to note as well that at FIP we went through the 2 letters from NHS England with particular regard to H2 winter prep, and then also the guidance around temporary escalation spaces. So we will be doing a self-assessment against that. That will go through SQ&I moving forward, just in terms of keeping an eye on our compliance against all of those areas. And I think we shouldn't underestimate as well the impact that the bed base, she says, touching wood, will have, if nothing else, more on staff morale, because they're very, it's been noticeable and understandable that because of the compression beds that we had as a consequence of improving our ward environments, the pressure has generally sat in one place, which is at the front door, and clearly that now is the opportunity to move away from that. And finally, lastly, I think we have learned a lot over number of us have done numerous winters here. We know that flu will be big this year. We particularly anticipate that it will be seen, the peak will be seen in January. So encouraging both home relatives, friends to get the vaccine for flu would absolutely help. Here, our staff, the health team, the vaccination team will be going out to ensure that our staff are vaccinated where possible as well.
Excellent. Any other questions or comments, Margaret?
Sorry, I'm sure it's encapsulated in all of the other areas, but maternity, I thought we reported out because we know we have a particular issue. We've got increase in bookings over the winter, so I'm surprised it wasn't identified on time.
Marion?
So, we can definitely look at that, Margaret, definitely, and I think Kate is coming today. It has been, difficult these last few whiles, and we are working very closely about the booking. And I was with Jenna yesterday, the head of midwifery at Newcastle, about what we can do in the future to work more corporately together.
A couple of governors raised with me the discharge and transfer unit, whether there is some delays built in through the process of pharmacy of getting prescriptions, and what was reported as lack of doctor availability there, and somehow the process was slower than it should be. You may not be in a position to respond there. But...
So we've got some additional foundation doctors within the organisation now, so, and we've changed the rota slightly so that there are named doctors to cover those units as well, so from the teams on the ward, so that should provide earlier access to sort of the medical input, but also I think there's something about in the flow improvement group, one of the things we're looking at as well is that process of when patients go to the discharge transfer, making sure letters are done in advance, making sure the pharmacy team are aware in advance, so there's not long delays for patients waiting up there, may just be waiting for transport rather than all the other things. So there's a bit of work going on around that as well, just to make sure the whole process is as efficient as possible.
That's great. I'd really appreciate a short note that summarises those steps so that to enable me to report back to governors. That's great. Jeremy?
It's just an opportunity to support the governors in that question, because discharge is absolutely key. And I think more than anything else, if we're not efficient in the way that we discharge it, we can just add time into the system, and in fact going home straight from the ward is, I think, always the best option as far as we can. And I think that focus and the use of the virtual ward and community teams and their expertise is going to be really important, particularly through the higher levels.
Good. Okay, that's been really full discussion, really good presentation. I really welcome the focus on recognising the potential impact on other services in the future, and I know that we're committed to kind of looking at that as the winter goes on. But otherwise, thank you very much indeed. And let's move straight on, shall we, to the Infection Prevention and Control Annual Report. Marion, you're presenting this. The cover says it's 23-24. 2 or 3 times it described itself as 22-23, but I think it was 23-24.
So thank you. And this obviously has been discussed in SQI as well, and it's Tamsin that's actually prepared this presentation, and she sends her apologies today. So obviously you'll have had a read through of everything, so I'll just very quickly go through it. I'm happy to take any questions. We are obviously rating ourselves as compliant, and this is a self-assessment, and we have been absolutely going through this line by line this year, and the teams have done extremely well. So really I wanted to concentrate on MRSA, because We have been caught out with this in the past, and I think the team have done a great job to try and reduce the numbers that we have. So going back to the last couple of years, we were 72nd out of the 138 trusts, then we came down to 38th, and then currently, although we're not at the end of the financial year, we are at 25th. So that shows the work that goes in. We're not complacent about it, but it's work that is absolutely ongoing. The same with Cedar Facile. We have been over our threshold there. The team have worked out a very strong action plan, and we are ongoing with that, and also a deep cleaning programme, just making sure that we're going through all the wards systematically to make sure that their cleanliness is up to the mark that we want, and we're obviously doing work with some laboratory testing. The MSSA, and Jim brought that up the other day when we were talking about it, because again, we can't be complacent about this either. But we've been doing a lot of work regarding lessons learned. We've been doing the nutrition and the hydration project, the catheter care, but also a lot of work in the community, because there isn't any point in doing everything from the acute side and not letting that continue in the community, or vice versa. Just some highlights I wanted to raise, because we have been doing a focus project group, and this is about sort of the frameworks, the opportunities, the compassion, the understanding and support. And Rachel Smith, one of our ITC nurses, has been doing this, and she's been going around with the team, spending time on each of the wards for a week in a non-threatening way, as a training and learning event, but also getting the teams to come into the IPC team themselves. This has been very, very appreciated, and we will continue with that. You'll see as well that we are continuing with the antimicrobial stewardship, and we heard about that the last day in SQI as well. So just really, the TAMS and the team are very keen to say thank you to everybody. It is hard work, this constantly, we need to be on it all the time, and particularly it's not just the general sort of infection control issues we're talking about. We do a lot of work with the surgical infections that we have, and that is, it fluctuates, but again, there's a lot of education both in the acute side, also in the community, but also with our partners in the councils.
Thank you very much, Marion. Well, once again, Alan, as chair of SQI, this was chewed over. Any highlights to the board?
Nothing to add.
Okay. Ruth.
Just two questions, Marion.
Yeah.
One, the NPC levels of training looked kind of
Turn on the mic,
disproportionately.
please.
Oh, sorry.
Yeah.
Looked disproportionately low compared to the others. And a minor point that we made reference to our sinks and face masks provision and having it manned, and I'm not sure it is manned anymore. Is it?
No, it's encouraged, but it's not.
Yeah,
it's
but
not
it's a
manned,
reference
so
to
yes,
saying it's permanently manned.
absolutely. And I think at that time it would be, but not now.
It was during last year, but it no longer is. Yeah.
And the training, we're taking that into consideration with along with the care homes.
Richard.
So I was going to pick up a little bit on Ruth's second point, really, which is great work by the Trust, but this is co-production between the Trust and patients and their visitors. Are we as crisp in our communication to visitors and patients on their responsibility in the compact as we probably are to our staff?
So a really good question, and obviously with visiting, we try to communicate as well as we can, Richard, and obviously the ward managers are pivotal to this, ward managers or departmental managers, because people are coming into other areas as well, not just the wards. We are trying to be consistent, and certainly myself, Bijou, if there's anything at all, our meds, they highlight it if it hasn't happened, and then we go straight away to try and find out what the issue is there. It's generally communication, and it's generally, somebody thinks, something else is happening when it isn't. So the communication has to be timely, but it has to be ongoing, and we have to make sure that, we are receptive to anything any advice that we get. We've been working with Joe's team as well, just to make sure that communication is as clear as we can get it. So I just think ongoing work. I don't think we can say that we've completely eradicated the sort of innuendos and the variances of things, but we can certainly say that we're working on it.
it's always good to hear the positive news, the positive progress, but when I was looking through and seeing our performance on MSSA and E. coli and Krebs, it didn't feel quite so Northumbria-like. You know, we weren't in the top 10. Do you have a sense of nervousness about that, or do you have a set plan for getting it?
I just when you were speaking
I'm sorry.
there earlier, I just mentioned it, that you'd mentioned it at SQI. And just to say that yes, we are. You know, nothing in this is complacent. We're thinking about different things every day. We certainly work with Beth's team as well with the laboratory testing. We also have to remember about our other trusts in the region, what they are doing, and make sure it's the same as us. So we are taking it very seriously.
Any final comments, Jeremy?
Well, it's just really on that point, Chair, because, and it's to take it back to Richard, particularly when you're talking about infections, there is a population demographic that is really important around antibiotic use and care that is given in other parts of the system. We work as partners with patients and staff and elsewhere, but not all of these things, I'm afraid, are entirely in our gift. But we're working as hard as we can. So I think those league tables they're not all.
They're a bit more misleading in this area.
Well,
Okay, then thank you. I think we warmly welcome the report, welcome the signs of progress, recognise that we're still focusing on how to take it forward, and recognising that this is a joint venture with the public and with the wider communities in which we operate. Thank you very much indeed. Let's move on now to the Innovation Research and Development Report. And welcome to David and also to Peter, sorry, I'm pronouncing it wrong. So sorry. When I alluded to a bit of lack of clarity as to whether the report was 23-24 or 22-23, it was this one actually. A couple of places it's described as 22-23, but I know that it was a report for 23-24, wasn't it? Over to you, Jim.
Thanks very much. I'm Dave Townley. I'm an orthopaedic surgeon and the clinical director for research and development, and Peter Heslop with me is the deputy director for innovation, research and development. So I'd first like to acknowledge Peter, who submitted the full report, and I've got 4 slides just to draw your attention to some of the highlights in the report from this year and sort of aspirations for next year. So we're very pleased to report that we maintain financial stability. The majority of our income comes from the Clinical Research Network that's to be rebranded next month to the Research Delivery Network. We are allowed a small increase year on year, and our performance indicators again ensure that we have secured that increase in funding. There is always a shortfall between our CRN funding and our spend. And we continue to bridge that with successful bids for CRN contingency money, external grants from places like the NIHR, and then a proportion of our income comes from partnerships with industry, which is an area of growth for us and a focus of the NIHR around the country. We also suffer from the workforce issues experienced elsewhere in the NHS. One of the areas that we've been very successful in developing have been hybrid roles. So we were one of the first to pilot research delivery fellows. So these are early years medics who have part of their 50% funded by the business unit, 50% funded by R&D, and they come and work with the delivery workforce whilst being supervised by clinical academics. And this has been really very well received, and we've had visits from elsewhere looking at this as a potential model for delivery. That hybrid role is extended into our NMHP workforce, so we continue to fund hybrid roles in pharmacy and physiotherapy. And this year we have piloted a band 8A in community that we hope will be sustainable over the next few years. We've been working with Northumbria University. We brought to this meeting last year a plan to co-fund and co-supervise PhDs with the university for NMAHPs, and that's now come to fruition with 2 active collaborations, and we hope that will be fruitful over the next 5 to 10 years. Our main metric is our recruitment to trials, so a busy graph, but the highlight is that we remain on the podium. We are second in complexity adjusted recruitment, so we don't just look at the recruits, we look at how hard the trial is to recruit to. We sit in second place to Newcastle, who are significantly larger and have significantly more funding. So we maintain that this is a real achievement. We've also seen a 20% increase in our commercial activity, which was an aim from last year, and we hope to continue that rise. And then finally, what's coming next? So we'd like to formally thank the exec team for supporting our bid for capital funding. NHR came out with a large capital fund just after COVID to increase infrastructure. We are looking to redevelop the clinical research and development, delivery centre, which is next to the maternity area at North Tyneside, into a new hub. It's yet to be named, but internally it's being called the Nerd Hub, Innovation, Research and Development. Watch this space for an official name. This is going to significantly increase our ability to recruit to commercial trials specifically. And it segues very nicely into a recent initiative from the NHR. They have asked for bids for commercial research delivery centres, so there'll be a number of these around the country, and we have put a combined bid in with NUTH to become a commercial research delivery centre. So we again want to thank the exec team for their support in that bid. Happy to take any questions.
Peter, anything to add?
No.
Let's come and go.
To Aries Human, 23, 22.
It's not the biggest issue.
I'll check it next time.
It's not the biggest issue. Thank you. Terrific report and really clear as ever. Questions, comments, challenge? Who'd like to kick off? Yes, Jeremy.
So I just want to thank the pair of you. I think we're in a very good position compared to where we were. I'm probably looking back about 5 or 6 years. There's really been improvement year on year. And this really is important for our patients. Institutions in which patients are cared for that have a strong research ethic have better outcomes. Long may it continue, and I can see that there's a sort of virtuous cycle developing along with the investment that we are getting from the NIHR. I just want to point out, I think the correct colour isn't that sort of yellowy bronze colour, it's silver, because I couldn't quite see whether we were second or third in that graph. And it's important that we're second.
The details in the report.
Very good. I'll just take Prof first and then, Alan.
Yeah, I think it's a very good report, and it's very important that our clinical activity is underpinned by a research philosophy, I fully welcome that. And is it making a difference? Well, the one way that you can actually measure things is the number of publications. There's a lot of very good publications in high quality journals, and you just got to assume that they are actually going to make a difference to patients. But we are playing our part in the development of medicine, so it's very good. Let's carry on doing it.
Great, vision.
Do more.
So just to support really what Alan has said there, then I think it's a really positive step in terms of having that balance between clinical interest but then having the research interest as well, and we shouldn't underplay the interest and impact it has for recruitment and retention as well, particularly the fact that we're now getting research fellows coming in much younger. It's not just the kind of people that have been around for however long. I think as well, the other bit we shouldn't underestimate is when you compare our size and the research activity that goes on, I think it is, I don't know quite how you proportionately measure that, whether you look at turnover, whether you look at staff, etc. I think is really, really positive. It's really strong as an organisation, and we shouldn't underestimate that. I know, talking to specialty leads, that for some of these trials, we are the biggest recruiters, even though we have neighbours who are arguably bigger than us. I think we shouldn't underestimate that. So I think we're really positive, and I think the new bill will be nerd will be, I like nerds, so maybe that will be a really good, will be a really positive.
And it's great there's a joint application with Newcastle as well.
Absolutely.
Not the first example listed this morning. Alan and then Alison.
The one thing I didn't mention was the fact that we're now encouraging our AHPs to do research, and our nurses, and whether black nurses should have PhDs or not. I think it's important that we give them the opportunity because they're getting it elsewhere. So that's good.
Is it on that point now, Indra?
Definitely, definitely give them that opportunity.
Good, then Alison.
Great. I suppose my other point is that it's great to see you're linking a lot with FDC who are really expanding their research potential, and I think that whole trajectory of research, and it's hard to know quite which the right home is for that. Is that all with you, with FDC, or is it separate domains, and how do we make sure there's linkages? But I think those conversations are really maturing, and it's great to see, because I think there is a lot more potential there across the board, and it's good to see.
Margaret.
It's a great report. You would imagine, I'm going to say this, it would be really good following this year's report that would focus a lot more on multidisciplinary, interdisciplinary healthcare research, because it is there. But I think exposing that and what actually impact it's actually doing would be really helpful.
David, Peter, any responses to those last set of comments?
No, it's just all really positive, and I think that the NERD is going to be a landmark regionally because there isn't an outpatient type department. You can see that footfall for research specifically, and I think from my perspective, patients volunteer to come to research every single week after being year after year, and they should be afforded that special area.
Okay. Good. Then you're right. Everybody's feeling very positive about the report, recognising the benefit that research brings, not just to, as it were, to the wider world, but to the practitioners who are involved in that research sector. There's no doubt in my mind that getting involved in research activities can sharpen your clinical practice or your practice across the piece. Encouraging that you're working closely with NPC, encouraging that we're moving into allied health professionals, keen to hear a bit more about multidisciplinary research, encouraging to work closely with Newcastle, and can't wait to become a nerd member. Thank you very much indeed, Thomas.
Thank you.
Thanks very much. Each year I chuckle at the heading Responsible Officers Annual Report. I want to do the Irresponsible Officers Annual Report next year, but meanwhile we're going to have to make do with Jeremy.
Well, I suppose if Dr. Doig is the responsible officer, that must make me the irresponsible officer, if the cap fits wear it. This is part of the national GMC regulations that this comes to board, and that the board supports the revalidation process, which we do in a number of ways. And that is a cycle around revalidating roughly a fifth of our connected workforce, which will include many of the doctors you've just heard about, on a 5-year yearly annual cycle and appraising them annually. You probably will have noted that the number of appraisals doesn't quite match the number of doctors that we have, but we actually had a really good year for recruitment. So not all of them are consultants, but actually quite a number are. So the number 91 and then the 36, which were the delayed appraisals. These are not people who don't get appraised at all. It's just they don't manage to complete their cycle within a year, and that's all done to a timetable followed up by Colin and the team. It's all going very well.
That's great. This feels pretty straightforward. Kate?
Just to expand on Jeremy's last point, it's mainly due to absence, sickness, maternity, that sort of thing, where they're not compromising.
You don't anticipate it, you can't see a problem that you need to be addressing. This feels like one of those that unless the board wants to challenge, we should be ready to receive. Okay. Great, then we're straight on. Katie, welcome, and what an interesting looking pilot you're about to tell us about. Can't we?
Good morning. So I'm here today to talk about the maternity and neonatal independent senior advocacy pilot. The pilot started in the spring of 2024, and the pilot was initiated following Donna Ockendon's inquiry into Shrewsbury and Telford. The Ockendon Review final report recommended that there was an urgent need to listen to women and their families and ensure that their voices are heard following their experience of maternity pathways of care. NHS England responded to this and instructed a pilot to work across multiple participating ICBs. Here in the North East North Cumbria, our local maternity and neonatal system has commissioned People First to undertake the pilot, and we're 6 months live. The pilot offers People First and the advocates working within the service to work alongside women, birthing people and their families, like I say, to absolutely ensure that their voices are heard following difficult experiences and outcomes following maternity care. They offer an opportunity to get resolution once the concerns have been addressed, open doors for further action, and understand the options to support our women in making informed choices whilst also navigating often complex systems, and offering an opportunity to signpost to other relevant services. The pilot has agreed criteria, and you can see on the screen that this is often following significant poor outcome during the pregnancy pathway. The criteria includes stillbirth after 24 weeks, if pregnancy and neonatal death within 28 days, if a baby is born with a suspected brain injury, if the mother has an unplanned admission to critical care, if the mother has an unexpected hysterectomy within the first 6 weeks following childbirth, or if the mother has unfortunately and sadly died. The advocates are reporting into the following boards, and you can see that crosses at the provider level, as well as the regional and also the ICB boards. The pilot has also been enabled to enable the advocates to report directly to trust boards. And we continue to work collaboratively with our advocate Annette, who was on site earlier just this week to support implementation and rollout of the pilot. The referral pathway can be a self-referral from the individual or family member. It can be a referral by health professionals or others working with the family, such as PALS, Patient Services, or our Maternity and Neonatal Voices Partnership. And it can be enabled through a telephone contact, the website, or an email. Following the referral, the advocate will contact the individual to navigate the next steps and will inform us as a provider regarding the start and end of the referral. We've established points of guidance here locally at Northumbria to ensure that we're enabling advocacy as an offer to our women and families. We're advocating signposting at the earliest opportunity, which is typically within an inpatient acute maternity stay. So that is typically delivered during the verbal duty of candour, and it is also written in our follow-up DOC letter to our families. It's embedded within our PSIF methodology, so we're talking and understanding if there's an indication for advocacy during our hot and cold debriefs, as well as during our after-action reviews and PSII investigations. So far here at Northumbria, we've reported our first quarter, and we had 8 eligible cases, of which 7 were signposted successfully to the advocacy service. There was 1 missed opportunity, and that was secondary to the fact that the advocacy had recalled the patient literature, and by the time we had the second version of the patient information, the service user had completed all follow-up in relation to debrief and outpatient follow-up following hysterectomy. So far in quarter 2, which has run from June to current, we've had 3 eligible cases who have all been successfully signposted. But unfortunately, despite our total of 11 eligible cases, none of our service users or families have accepted referral into the advocacy pilot.
Okay, so thank you, Katie. That was a kind of a downer in the last sentence. Am I misunderstanding it? Is it feeling like you've set up an elaborate process, but actually it's not what people are wanting?
I
think it's hard to understand. I mean, we have a strong family liaison, for example, already through our bereavement pathway of care. We have a fully embedded birth reflection service. So family engagement and liaison has always been a priority following adverse outcome. I've spoke to Annette earlier this week to understand the position outside of Northumbria. There are still 4 providers that aren't even signposting yet, so I think we are ahead of the curve and that we've got embedded processes. But it'll be interesting to see, you know, as we're 6 months into the pilot, it's a 12-month scheme, what that will look like at the end. Comparatively, we've got a similar number of accepted referrals across the North East Northumbria as West Yorkshire, but there are other areas in the country where there has been a significant increase in the uptake compared to the North East Northumbria.
Do we know where there's been an increase, whether that's because, I'm going to say, all those other bits of the service don't exist? I'm just wondering whether is there anything here that, because we do, and we have done for quite some time, all these other areas to support in such sad circumstances, that actually people don't feel the need to do that. It'd be good to just to see where the advocate role has seen positive results, whether they have any of those other processes in place.
I agree, and South Yorkshire was an area I think where the uptake of advocacy has been quite prevalent. So we went back to People First and Annette, our lead advocate, to understand some of their processes and anything we could learn from them to implement locally. And we asked Annette to do that on Tuesday, so we'll wait and see, learning from other parts of the country.
Okay, Joe, and then I'm going to be inviting Margaret as the maternity champion to comment.
Thanks, Katie. I think it sounds an amazing piece of work. I just wondered whether there's been any conversations with the Maternity and Neonatal Network Voices partnership around why they think women may or may not take up. Because I know the obvious thing is to ask the women potentially, but if they're not engaging, they may not engage to tell you why they're not taking up the offer. But I just wonder whether the Maternity and Neonatal Voices partnership may be able to give some insight if we don't see that.
Of course, and our MMVP lead, Ray, has been really pivotal in the launch of our materials and our posters and using our social media to ensure that our service users are aware of the pilot and that we're an active site for the pilot. So absolutely, Ray would be more than happy to survey.
Margaret, maternity champion.
Yeah, so I have met Annette right at the beginning of the pilot, and I've met her more recently. I was really interested because I think Katie's identified the service that we have at Northumbria is excellent, and the women have built a really strong relationship with their midwives. And so one of the challenges I put to Annette is how good this service would be if you had such an excellent wraparound service within your organisation anywhere. I think, Katie, you've asked the right questions. We need to look at the indicators nationally and where areas you haven't done as well. Is there an uptake because there wasn't a service there? And it's interesting, it is a pilot, it does sound really exciting, but I don't think it really adds anything to what we already have, and I'm being really direct there. And I did have that conversation with them.
Well, that's the purpose of a pilot, of course.
Yeah,
I mean, we shouldn't assume that every pilot is going to be a glorious success. So, good if we're learning from it.
And I think we just need to acknowledge Bijou's point that not all services have a birth reflections opportunity to come back at a juncture that's psychologically appropriate to reflect on the birth experience and understand the events. And it may be that there's disparity across the country that's resulted in the difference in the uptake during the pilot.
I was really interested that the pilot's being driven by People First, which I've always known as an organisation of people with learning disabilities. And I hadn't realised they're branching out into all other areas.
So yeah, RICB commissioned People First, but you're absolutely right, the background is with learning disabilities and walking alongside those families.
Right in the mainstream. Chris.
So just one last thought. Are we confident that we've got like the marketing and the offer and right, you know, that actually it's not just how we're explaining it and how we're promoting it that is the issue?
Yeah, I mean, we're visually sharing through our, for example, our pregnancy assessment unit. It's on our notice boards and it's on our reel. It's on our social media. We're discussing it face-to-face during DOC contacts. They're getting a follow-up statement in their written DOC. So I feel like we're continuously revisiting the offer. I had a personal experience following a tragic maternal death with the husband of the lady, and he was quite specific that he'd been offered advocacy 3 times. It was important that he didn't want to be asked again. He'd made his decision, so you have to get the balance right. That was a case that had crossed providers, and he'd been offered at Gateshead and he'd been offered at Northumbria. Then I revisited for a 3rd time, and he was really clear that he knew that there was an offer there. So it's just understanding the circumstances and being sensitive to the requests of the family also.
Okay, very good. Well, a really interesting paper, an interesting parlour, well presented, fascinating that what we're learning, that actually the strength of our existing services may mean the Parliament is less relevant to us. We just need to make sure our eyes are open to still pick up whatever learning we can from the process, even if it's not going to be a learning that says we need to roll out the Parliament as originally designed. But Katie, thank you very much indeed for your presentation. Good. Then we're still within the overall heading of patient and staff experience, and we get an update from Jeremy on staff flu vaccination.
Thanks very much, Chair. This is to just really inform board as we need to that this is a key part of our winter delivery plan, that we've funded and supported the vaccination team to undertake our vaccination this year. It is identical pretty much to last year in the way that the COVID vaccine is being sent to us. We aren't able to give that to all staff who are eligible to flu vaccines as we had done over previous years. So I'm hoping for a fantastic uptake with flu before the predicted rise that we're seeing, we're predicting this year, because we're definitely going to be needing it.
Thank you for that. Okay.
Thank you. Just to add, because we've had a bit of discussion about this in People and Culture Committee as well, because last year we didn't get the uptake for flu that we all wished to. So we have made some changes this year to make sure that we can promote it a bit better. So we've recruited a permanent team, so we're not just relying on bank staff and their availability. And last year we booked appointments and then put a roving team out in all the high-risk areas. We've done that first, and we're sort of starting that straight away now. We've increased our offer to out of hours 7 days a week, not just a 9 to 5 type offer. And then we're looking at some videos and trusted voices of people who have had the jab, and they want to give that accolade to people. And then QR codes in canteens, restaurants, just to say this is how you book your appointment. And we're also supporting the PCNs out there as well, because we've got a permanent team now. So some changes I'm hopeful will work.
Good. Well, you recall that last year we were, as a board, we were a bit worried about what felt like quite low take-up and a dip in take-up. So it sounds like we're doing our level best to get it up further. Is there anything further you would want from the board? I mean, I think you can assume a strong message of not only support but really powerful encouragement to staff across the piece.
I think for this campaign we're trying to look at peer-to-peer sort of campaign.
Yeah.
I think that's
sure that's more effective.
Very strong.
Yes, I understand.
2 points. One is that the evidence from Australia is that there's a very good antigenetic match between the vaccine and the circulating strains, which is always useful because there have been a year where the match has not been great. I think there's also quite an emerging psychological evidence that one of the main drivers for it isn't around protecting patients, it's actually around protecting yourself. So actually saying to people, actually have a flu jab, okay, you might have a sore arm for a couple of days, but that's better than a week of feeling miserable with flu, is actually getting more support than get a flu jab to protect your patients, which has been quite a lot of the NHS focus in previous years, and it's probably a course that's running a little bit dry now.
Shame that, isn't it? Okay, but yeah, we need to listen to the evidence. I've got Ross and then Jeremy.
Just to reassure that the team's working with the key leaders and that there'll be lots of things happening. I think one of the challenges is always around community, isn't it, and getting people out and about and not being able to kind of send things to have it done. But again, for those of you who were at the celebration event yesterday, the team were there making a really good start on capturing, probably the wrong word, but staff who turned up for that and doing sort of good business there. So a good start.
Okay. And just to point out, Chair, that there are different attitudes to and different evidence bases between flu and with COVID, so we should look at both of those numbers separately, albeit that they're important for frontline staff.
Okay. Good. So happy to receive the report. Continuing to provide strong support from the board, encouragement, understanding it's complex and the communication messages need to be quite nuanced, but glad to hear of the active steps that have been taken to try to up the numbers this year. Good, thank you very much indeed. Do we have Andrea here? Oh, she's coming online. Right, can we do a switch round then, please? Because we're Joe, patient charter 4.4. Okay for us to take that now?
Thank you, Chair. So I'm delighted today to bring the new patient charter for Northumberland.
I'm really sorry, Joe. Andrea has just joined us, so I'm going to switch in. That was a short report, wasn't it? Andrea, welcome. We've just done a little shuffle. We've shuffled you back into position. Thank you for being available to take us through the GMC National Training Survey. You'll know, because I know you've been here before, we will have read the paper, so you don't need to take us through all the detail, but just pick out the highlights for us, please.
Thank you very much, and apologies I can't join you in clinic out in Hexham. So thank you for your time. Yeah, I think the highlights are that there's been a very strong performance in education and training across the trust. The data from the GMC is difficult because each year they change how they report the system. So, for example, I think I put it in the first page that in stroke there is some inconsistencies with how the data is being presented. There's a pink satisfaction score, which is within the normal range, but it's at the lower end. But then they've got dark green, so we've taken that forward with the individual teams. But I think in general there's been a very good performance across many teams who have had exceptional ratings, which is just testament to the drive and the enthusiasm of the teachers in those particular areas. On the second page, I mentioned about the regional performance, and just to highlight that, yes, we've been picked to the post by CNTW and CHUV, but these two mental health trusts have got a smaller number of trainees and they're only in one specialty, so their rotas are less complex and there's less of them to train. So I think from an acute trust point of view, we've done really well in the last 12 months. Now, that doesn't mean that we're resting on our laurels. We do know that there are still challenges for us, especially with regard to the supervision requirements that we have across the trust. And I've had conversations with colleagues as to how we can try and improve that going forward with future job planning, just to ensure that we do have enough supervisors across the patch. When you go to table 1, you'll see a lovely array of whites and some dark greens with only a few pinks. There's one red, which is a fantastic achievement because most trusts get lots of reds, and this is only in induction for the gastroenterology team. They have an action plan in place to how they can address that going forwards. And when we look at table 2 for the table by satisfaction by programme, again the only area of red for this academic year is surgery FY1. And again the surgical team are doing a deep dive as to the action plan they have put in place in the last 6 months and how that can be improved going forwards. So I think it's a really good performance for our both trainers and our resident doctors, the new terminology that we're using for doctors in training. So I'm more than happy to take any comments, but I would hope the board would be satisfied that we are continuing to show a good, strong performance across the trust for education and training for our resident doctors.
Andrea, thank you first of all for an excellent presentation, but also an excellent report. And as I regularly say it's great that you also pick out the areas where we've still got further improvement to make, and you talk about the steps that have been taken, which I think are really important. I love seeing 47 out of 48 of the 47 questions where we're a positive outlier and only one where we're below the benchmark. That felt really satisfying. You said we're just pipped at the post by the Mental Health Trust. I think we're also pipped by Gateshead, but
we are, yeah, sorry.
But let's not become too competitive in this. But it was still a really good all-round performance. I've got Richard first of all.
First of all, just need to remember this is against the backdrop of industrial action. So we've gotten through that period with such good results. Yeah, it's quite remarkable. So it's
Are you hearing this, Andrea?
Yes,
yeah,
yes,
yeah.
thank you. Yes, thank you.
These are not a surprise. I mean, Northumbria, when I was at Newcastle University, was traditionally the top of base units for pre-graduation training. So for that to reflect through into the post-graduation training is not a surprise. I think it's testament to what's been going on over many years. So well done to Andrea, to you and the whole of the team.
That's great to hear, isn't it? Alan?
Yeah, well done. I mean, it's a testament to all the work that everybody has put in. I mean, training our resident doctors is everybody's business. And to show that we have been through phases where it hasn't been as good as it could be. But I mean, I think we need to find some mechanism of the board recognising what all of our staff have done. I don't know how you do that. It's put us in this really quite strong position, because not only is it good for the trainees, it's very good for the future, that if they have a good experience here, they'll come back and work here and be recruited as our workforce for the future. But I would like to find a mechanism to just thank all of our staff who do all this training.
That's an excellent and constructive point. Bijou, how can we...
So I think a general board note would be really appreciated, that Andrea can send out both to the education team but also our educators, I would say. I think it's worth noting that we have made comment as well. There's a lot of national discussions about productivity, as you're probably all well aware, and one of them is around consultant job planning. And we have flagged that whilst we understand the need to match capacity and demand, we shouldn't underestimate the need to make space for training in people's job plans, which is some of the points that Andrea raises, because whilst you can't measure that with productive outputs from a patient point of view, for example, it does have a longer term impact. And I think to your point, Alan, that if we invest now, we've got much better benefits to come later on.
There you go, Jeremy.
So, congratulations, Andrea. You undersell yourself and the team. You've done an absolutely magnificent job, and I just wish you were all the very best in what you're doing, but wish you were staying longer, because the last 6 years have been really nothing but good news. Anyway, so that's just my own personal regrets. Can I just ask, in terms of overall numbers where we sit, because obviously we are bigger than Gateshead and CNTW, because there are now trainees and training doctors and students absolutely everywhere. We have got every nook and cranny filled, so which is a challenge, and to manage that expansion. But I think we must be amongst the bigger training organisations in the North East.
Actually, we're one of the biggest training organisations in the country, Jeremy, and that's something that you can't get out of the GMC survey data. So we, whilst I'm talking, I'll just see if I can get into my emails to get a summary from the deanery that we've recently received. So for Northumbria, we are competing against those specialty hospitals that you will see in London, such as the Royal Brompton, the Eye Hospital, where those sites have got single specialty trainees in small numbers. And so we are really punching above our weight with regard to the complexity of training that we offer and the volume of training that we offer. So when you kindly appointed me 5.5 years ago, we only had 190 trainees. We're now up to 370, and that's due to the testament of yourselves in supporting me and our team, but also our trainers across the board in actually delivering this high quality education in large numbers. And we couldn't do it without the training enthusiasm from our colleagues, really. Sorry, I'm just trying to see if I can find the national data. I can't find it.
Honestly, Andrew, don't worry. You've given us the flavour, and that's really.
So just coming, if in my head I'm imagining a volume times outcome that puts us absolutely up there.
Not that he's being competitive. I'm going to ask you to stand down that task, Andrea. We don't need to sit and wait for that one. It's just too much internal flattery. I think we've given you enough flattery for now. The board is obviously delighted not only with your presentation, but with the work that's been going on. I didn't know that you were leaving your post as Director of Medical Education, but I'm relieved to hear we're still retaining your services. That's right. Yeah. Okay. Well, thank goodness for that. So achieved all this despite industrial action and what we know has been quite a toxic environment for many resident doctors. So something really is working, and we've agreed to Alan's suggestion to find a way of communicating the board's support, not just to you and your staff, but to the wide range of people who've been involved in this outcome. Thank you very much indeed. And I was going to say see you again, but if we do, it'll be in a slightly different role or function. Thanks very much indeed.
Thank you very much, and I will forward that email across when you get it to me. Thank you.
Lovely. Okay.
Bye.
Now, Joe, second bite, second try. I love this topic, and it's one that's been discussed in several places, including governors have had a lot of input to the development of the patient charter, and this is being brought to us now for our agreement, I think.
Thank you, Chair. So I'm doubly delighted to bring the patient charter. So the sort of basis of the charter itself is it is to build on the great work that was started by the Realistic Medicine group. This was always an ambition, and Lindsay and Jeremy and the group had started the work. And we've just picked it up and ran with it. So the overall aim of the charter is to continue to enhance and improve our patient experience by looking at a set of standards for the interactions that we have with our patients, whether it's the information that we give them or the conversations that we have with each other. It's been co-produced across, as our chair has said, with our governors, with our lay representatives, through the Whale Cafe, with the third sector, and with our staff. And it's been taken to SQ&I where it's been approved. So these are the 10 principles that we have, and as you can see that it looks at how we involve people, the information we give to them, how we listen and understand and we see them and we understand what matters to them, how the letters that we write to make sure that they're written in a format that is understandable. We understand people's preferences and the things that are important, and we're not asking people to tell those stories over and over again. That our patients know who it is that they're having that interaction with, their job role, their name. So it's all of the things that we know evidence-based really matter to patients. But as I say, most importantly, this has been co-produced and co-designed in partnership across our organisation and the people we serve. So the most important thing is we can have those 10 principles written down, but it's what we do with them that really matters. So we want them to become business as usual within Northumbria. So we know there's lots of great work because we measure aspects of the charter already through our programme. But to look at how we really embed it into our DNA, as I like to say, in terms of our patient experience programme we have, is we've brought together a group of professionals and 2 of our lay representatives to create a working group. So we've tasked ourselves with looking at some actions that will help us to start that journey of embedding the charter throughout our business as usual within the organisation. So we've met twice now, and we've started to develop a baseline measurement. So we've developed a survey in which we're going to measure ourselves against those principles in particular. And the plan is at the moment potentially to start with our patients. And then we're looking at some of the things in which we may integrate the charter into important aspects of the trust. So one piece of work that we've started already is I've met with Joanne Sunderland, and the charter will be integrated and aligned with the I statements, the CQCI statements, and that will become part of the quality panel. So it will be, services will align themselves against those statements and the patient charter, and our lay reps who now sit on the quality panel will be there to hold us to account about how our services are aligning with that. There are also some plans to start with a quality improvement project, which at this stage we're discussing potentially in the letters and looking at how do we look at how letters are written to our patients, directly to our patients, and in a format that's understandable and is accessible to all of our patient groups. And that ensures the charter.
I think this is really exciting stuff. I know one always has to tread slightly carefully and not shout too loud beforehand. I'm just really tempted to start seeing this on posters in every corner, but you would probably say not yet, because at the moment they can say, well, you're not doing it yet. Is that, am I right? Yeah.
And I think one important aspect that we've spoken with Ross about is we definitely want to make sure that our staff are aware of the charter, because if we're working towards that, and in terms of shouting about it to our patients and our communities, we need to make sure that every part of our organisation is aware of this.
I get that. Ross and then Jeremy.
Just to reassure you though, that process is underway. We had a very good meeting with the group, didn't we, last week or the week before, where we discussed a lot of different ideas and threw some different things around about doing exactly to see getting that out. It was very positive, so we'll run plan very soon.
Jeremy?
So we're building on a great start, I think, so I think we will be pushing at an open door, but I just really want to say that it's not just you that's being held back, Chair. It's me, because I really am very, very serious about this, and I'm very, very serious that we will do this as an implementation endeavour alongside our public, because we really do need the people who use our services to see what we say and commit to, and for them to give us feedback on that basis. And I think that will be the most powerful element of this. It will give the teams further, deeper information, and it is just the start. It's our first version of it, and it's a serious commitment to communicate to and about those that we care for in better ways.
That's great. I've got Steve and Ruth.
Well, I think this is a great piece of work and should be celebrated as quickly as possible, but I definitely think that your kind of caution's well-founded. My question really could be to you, Joe, or to Kate. I think the appraisal process is a good touch point to be able to reinforce those messages, but I know that appraisals have been a bit of a pain point in recent years, and we've had to simplify it to get greater traction with staff and managers. So I just wonder how we square that so we don't lose the great progress we've made with the appraisal process, but we don't miss the opportunity to reinforce these messages.
It's a good point, Steve. We'll have a think about it. Thank you.
Great. Ruth?
Okay, I think it's brilliant. Sorry, I think it's brilliant. I really like the fact that we're kind of saying we're going to help you to help you. I think that's a really positive message. It's not all what we're going to do, it's about how we make your relationship with us work better, which I'm glad Jeremy said it's the first go, because I do think there'll be things come out of that that say we're going to need to change it, and it's not, this isn't written in stone. So I think that's the real key for me, is that we listen to that feedback. And I'm assuming, because you monitor everything, therefore you'll be asking people in your questioning about do they know about it, what do they think, or have they experienced it? Because I think we do need to track if it is hitting patients and if they think it's the right thing.
Yeah, I absolutely agree with you. The discussion around the baseline measurement is the easy bit, because we're designing a survey we'll measure, but I think it's then how do we integrate that measurement into our existing programme so that we're continually checking in.
Okay, that's great. So, co-production, and a number of organisations talk about it, and it's not easy to do. It takes longer. You have to listen to some people who've got the long ideas and find ways of working with a range of views. You sometimes end up as a board with wording that I remember saying, that first principle, it really needs simplifying, and I'm told this has been co-production. It's almost irrelevant what you think. A large number of people have come to this view. So congratulations on the process as well as the outcome. We understand the caution. We're behind moving as fast as feasible, but no, not too fast. Important to get the monitoring and the feedback in place. I think we'd like to, I mean, you come here anyhow, but let's get a proper update in due course. You can tell us when due course is, but let's make sure it's on a future agenda within reasonable time and scale to hear how it's going. Okay? Great, thank you. Then we're still with you, Joe, the patient and staff stories. Some really interesting stuff around stoma.
Yes, so we've had discussions about food on patient provision of food in board before with patient stories, and we know how it is an absolutely important aspect of patient experience. So I thought this would be a good example of where patient experience measurement has driven change and improvement. So the stoma menu came from the feedback that we gathered from patients through the real-time measurement programme and the conversations that our coordinators had with those patients. So as we've been doing more recently, we've tried to bring you a range of views because we think that helps to give a more balanced view of the different aspects of different patients and their experiences and different staff. So for this one, it's, as we've said, is around the development of the stoma menu for our patients that have a stoma. And I think the things that stand out for me in terms of the range of experiences from our patients is they talk about that the menu has helped to simplify choice for them, particularly when you are new to having a stoma as a patient, because there's a learning process in terms of what food is suitable, safe for me to eat, and the worry about that, so it's helped. I think the flip side in terms of any negatives is they talk about the range of food that's available, so it can feel quite limited in terms of that. The patients talk about the fact that the menu is itself, so some patients who are quite expert in their stoma will continue to choose from the main menu because they know what they can eat, but then the worries about food wastage because some of the things that they leave, and we know that's important to us as an organisation around waste, but it's also important to our patients as well. The staff story is from a stoma nurse, and you'll see in the patient stories that they reference to what the stoma nurse and Kelly and how the support that she's given to one patient in particular. She reflects that generally the patients do enjoy the menu, but acknowledges the limited choice that's within that menu, and she does feel that there's a greater need for education and awareness on the ward so that those menus are shared routinely with patients. The catering manager who was in place when the development of the menus was completed, I think she gives a really good broad insight into how the menu came about. She talks again about a need to raise awareness, and particularly that there's pictorial menus in a more broader sense for our patients who may have dementia, etc. But she also talks about that they plan to review that menu in February 2025, which will potentially give the opportunity to be able to work with our provider to look if we can broaden the range of food that's available.
This is a really rich set of stories, charting the story of, first of all, something that came about as a result of concerns raised, progress made, but then the feedback being mixed as to the quality and the range, etc. And now I thought a really thoughtful set of thoughts from Dawn Palmer about how to take it forward, whilst recognising it's quite hard because it cuts across organisations, isn't it? It's not just, I mean, there's an NHFM element, but there's very much a nutrition assistant element, and it cuts across. And it hasn't always been easy, but I found this a really encouraging story, as long as in due course we get the next stage in the story, which is, so what happened next? Anybody like to come in? Yes, Mary.
I think it's a great piece of work, and I think it just shows the need for the communication, particularly with the colorectal specialists, but also the nutritional nurses. And I think that partnership people, but I think we need to have a bit more education about what that actually means for those patients, and actually if you give the wrong kind of food, the implications that that has, because it's not easy for these patients.
And every visit I make, people speak positively about nutrition assistance. I just think it's a great initiative. So, yeah. Okay. Well, that's great. Thank you very much indeed. We've gained a lot from that. And then the patient and staff experience report.
So
this is familiar territory for us.
Yeah, just some headlines. So in terms of our patient experience performance for our right time, so that is our external measurement, where we measure day case, outpatient and inpatient. With our day case, and outpatients, we've seen some good statistically relevant improvement when we compare across our May, June, July reports. For our inpatient over time, we continue to see some decline. However, we have returned to the top 20, to sit within the top 20% score, and our outpatient performance continues to be within the top 20% through the right time. When we look at emergency care for our right time measurement, we do continue to see that decline over time, but we still remain within the top 20%. And just a point of note that NSEC has returned as a site, when we look by site level, is returned into standard variation for the last data set. We've talked about this already today, but we know that the areas for improvement when we look at a question level relate to waiting and pain management in particular. When we look at our real time for ED, I think we must acknowledge, and I know it's been a quieter time with holidays, but in August we've seen some great performance across all domains. So the average score was 9.24 out of 10, which is a phenomenal scoring comparatively over other periods, and 8 out of the 10 domains were 9 or above. And I just have to say the first report in September has demonstrated continued improvement, and it was so that was great to see. In terms of our real-time inpatient measurement, we see our scores across all of the domains continue to be exceptionally strong. However, food is still an area that we continue to focus on, because our ambition is to reach the heady heights of the top 9s and touch in 10 with our food, like our other scores. Our patient experience platform, which is our AI technology that we are piloting at the moment, where we are able to analyse the reviews that our patients leave on social media. We continue to demonstrate a strong performance when we compare ourselves regionally and we compare ourselves nationally, so it's scored out of 5, and our score is 4.3 out of 5 compared to 3.7 regionally and 3.6 nationally. And I know I've said this before, but I feel quite passionately about this because it's patients talking about what really matters to them, and feel driven to do that on social media, so I think it's a really important aspect of patient experience. Moving on to staff experience, so our July survey has been published. We continue to see that systematic slow decline on our scores across the July when we compare with the previous survey in April. We see some statistical decline when we compare over the last 12 months. So looking at that, we wanted to deep dive into that, and we took 2 of the really important advocacy questions, which are, would I recommend this organisation as a place to work? Would I be happy for a relative or family member to receive treatment in this organisation? And we deep dived into those in August, and we asked our staff to tell us more about that, to really give us some insight into why our staff, how our staff were feeling. We've collated all of that information, we've pulled it together into a presentation for our business units. We give them an indication where their lowest performing teams are, and we share that, and currently our business units are having discussions at team level to really understand locally what are the things that would help to improve their experience. I was a head of department meeting yesterday for medicine, and we were having that exact conversation about the conversations they're having with their teams and departments. And one of the things that we talked about in PCC this week is really having an action-driven discussion about staff experience. So we've got lots of data, really important data that indicate where we need to focus. But I think we now want to step it up again and really talk about the actions that are happening locally within our business units and our subsidiaries. And just to say, the National Staff Survey is charging towards us now, and it's starting on the 7th of October, so all of the preparation work in terms of promoting that with our staff and encouraging them to take part, because it's a really important survey for us in Northumbria, and is well underway now.
Great report as usual. Bernie, do you want to add from the PNC?
Yeah, thank you, Chair. I think, first of all, just I was only having this personal reflection on the journey with staff experience in particular. And it's not that long ago, certainly when I first started 6 years ago, we were just in the very early foothills of doing staff experience. We've come a million miles. So really good rich data. And by and large, we're still one of the best nationally, albeit by our own high expectations. A little emerging concern, like Touch, around this slow decline. But we had a really thorough, challenging discussion at People and Culture just earlier this week. And as Joe said, we're just going to change gear a little bit through People and Culture in terms of some more targeted kind of deep dive on a kind of selective basis, just to get that extra reassurance, but in a support and challenging way to the business units, just to see if we can just use the data to affect that change positively. So, but great stuff. We're in a good position. Let's not lose sight of that, but we just want to kind of change gear a little bit internally.
I totally agree with that, Benny. I think at the head of department meeting yesterday, we had that exact conversation. We talked about if we compare ourselves nationally, our scores continue to be strong. But one of the things we do in Northumbria is we benchmark against ourselves, and we always look to improve, don't we? And that's where we're at right now.
Of course. Kate?
Just to add, so we think there needs to be that additional accountability to the business units for this service. So I think there's an over-reliance on Joe's team for working with teams, etc. And it's the leadership in the business units that's going to affect a lot of this stuff. So they'll be coming to PCC on a regular basis with their action plans, and they'll be held to account on what they're doing.
Well, we saw clearly from that earlier item within clinical support and cancer services, the range of responses is extraordinarily wide, and we're making a mistake if we aim our interventions kind of across the piece. There are some areas that we really need to focus on, and it's likely to be really quite individualised responses for unit by unit, I think. That's great. Any more on this most important of topics? Great, thank you very much indeed. Then can we go into the board walkabout? So I continue to be grateful to board members who carve out the time to not only to go and visit and represent us all in those visits, but to come up with creative thoughts and ideas from it. So the first one, Andrew, you were in NSEC. As ever, you can assume we've read the report.
Yeah, so Alistair and I went to theatres here, and really interesting set of conversations that came out of it. I guess probably use the time here just to pick up on some of the sort of challenges that come out of that, and all of that in the context of, I think, everything we saw, we'd be absolutely happy to have a family member there, or, you know, it was all really impressive. So, you know, everything I say that's by way of kind of challenges is in that context, I guess, and that probably the underlying themes that we kept coming back to in various different bits were around space. So it's at a real premium up there, and that leads to some other things. I think there's a real kind of culture theme to talk about, particularly around, and there's elements of the culture within theatres is changing, like we talked about the use of the robot a lot, but then there's also this sort of slight sense of otherness that comes in any bit of an organisation where you have a sort of locked door that no one could go through without a specific reason. So we did talk quite a lot about things that were maybe a little bit different for theatres, and I picked up since started having a conversation with Kate and Mary about some specifics around that, just because I think there's probably some things to pick up. And the other thing I was really interested in was around stores. So we've been talking a lot around inventory management, and so I think it was just important to go and see that for real. And so with that in mind, I guess that, you know, I'll read everything out that's here, but it's a real challenge getting just all of the things that they need to do their jobs in there, and they've done an amazing job just getting everything in a workable place, but it really shows where maybe it's because we don't go there every day that it's sort of, you know, more obvious to us, but everyone does these sort of, you know, dances around things because everyone knows where objects are, and because it's so not necessarily clustered in the space, but just full, where there's a lot of just navigating around everything that's a real problem. And they
do manage to keep it tidy and safe, but it's been a real struggle just getting all of the things they need to have there. And they were very open with us and let us sort of look in the cupboards and that kind of thing. So, you know, got a real sense of especially kind of moving the robot around and risking damaging it at times, and kind of some of
Only
the...
a couple of million, who cares?
Just bash the odd door frame with it on the way through. Sorry, go on, please.
It's really interesting, isn't it? Because you think that the hospital, those theatres in particular, have been now open nearly 10 years, and the robot wasn't
Exactly.
even around then. And
Yeah.
it's how we keep up with that. At the time, they were built obviously with the clinical teams involved in the design, and there's not very many places that get to build theatres from scratch, but that idea of we having these compact but large robots moving around probably weren't even in the mind to think about how would we accommodate
Exactly.
that.
And they've jumped through so many hoops. Like when we were there, the theatre that the Da Vinci robot in wasn't using the robot, so they were sort of talking us through how it was going to need to be decontaminated before they could then use it in the next procedure. And it's just, they're doing so well in a very constrained, what is now, in fairness, a very constrained space. So I think that was worth calling out. And then on the robots as well, the other thing we picked up a bit was it's quite a tough working environment. So, you know, they talked about the noise and they talked about lists overrunning, and the thing that really struck me was just when they were saying, oh, you know, we used to all love working in that theatre, and I want to kind of try and keep that, but it's quite a sort of challenging working environment. So I think there are a few things like that that we could maybe pick up on, and some of it's quite sort of structural, and some of it will be, I don't know, there's other things that we can alleviate, like not having an expectation of lists overrunning, or some of those kind of things. And so that was interesting. I guess I'll zip to stores rather than unpack all of this, but there's obviously just a constant effort there of keeping everything to hand, and it's a funny shaped, like a curved room is not the natural shape of a shelf, so everything they do is kind of difficult right from the outset, but I think there's an awful lot to do around, we've been talking about inventory management, there's an awful lot to do around that, and I think there was some kind of, you know, some excitement about what we could do, but also a bit of, well, you know, we need to see it to believe it, because they've been through a few rounds of this, so it's very useful to pick up on that, but absolutely amazing team doing a brilliant job, and I just think we need to have a think about what we can do about the space.
Okay, Paul.
And I've picked that up with the Kent, so I've heard about the all around walls and all that, and differently in terms of storage, so I've asked David that around the visit, have a look and see what we can do to reconfigure this space if possible.
Excellent. Any questions or comments? That's a round set of topics. It would be helpful to to see a response in the round at some point, but quite light touch without having to dig too far. Jeremy?
So I suppose just reflecting on the comments from Lord Darcy about capital expenditure, that there is a lot more stuff. It's not just in theatres, but particularly in theatres in the radiology departments, that is required to run, high quality healthcare. And whilst we've got great buildings, we do need to have a little think about how we do just in time better and get storage away from, but at the same time we need absolutely everything. And so then it is going to be difficult to alter the actual footprint of some of the places, but getting them working better, I think, is something that we definitely need to think about doing.
And some of the other issues Andrew raised, we know about before, the cultural issues, we know it's work in progress, but it's good for us to be grounded again, to hear the outcome of that visit. Marion?
Yes, thank you for going to the auditors. I think it is quite a unique place to work, and I think it's a bit like radiology. They work in very different conditions, and they have wards and departments, so they're in an area with no windows, and they've got the noise, but they've also got bright lights, and I think that does affect you. So I think we have to be very mindful of their health and well-being, because they are constantly there.
Okay. Thank you for the visit, some useful learning. Richard, you had fun in Rotherham.
Yeah, so this reads as a bit more of a travel agency than
Yeah, it does.
It's because I think not many of us get the opportunity to go to Rotherham, so I wanted to give a little bit of colour around the description of the place. I'll just say upstairs is stunning. You can read the rest of it in the reports. If you do get the privilege to go to Rothbury, go into the community nursing office on the ground floor, and on the wall there is a map of their patch. It was summed up by one of the Berwick governors earlier this week as being equivalent to the area inside the M25. And that analogy struck with me. And you need to remember it's a 2-hour return journey from Rothbury to Patience, and there's another hour and a half the other way return journey to Wandsbeck as the nearest base unit. By my maths, that's 3.5 hours of travelling to get into a base unit. If that's for a blood test, that is not going to be a great experience. I know the numbers will always focus us on more built-up urban areas, particularly those with deprivation, but we do always need to remember, I guess, the people out in the isolated rural areas, because for that individual it's a pretty miserable experience if it goes wrong. I think the community nursing team there are fantastic. Marion's getting them some waterproofs now, so hopefully it'll be a more fantastic experience for them. And it's just great to see them, and it's lovely that we are getting to see more of the community teams. I know we commented at board about a year ago on we needed to get to see them, and it was less obvious how you do it because it's not a big brick building, but actually we've managed that quite well in the last few months, and more of that we can do the better.
That's great. Yes, please.
Can I just ask as well, so just on the back of that, Blythe community team are based at Blythe Hospital, so there is, just in terms of board walkabouts, there's an opportunity there as well to see that team who work well with the ward, but also, so it's similar to Rothbury in terms of that proximity and helping and knowing people that are on the ward, but also being out in the community, so there's an opportunity there in terms of board walkabouts.
Good. I think that opportunity to kind of get more than one service in one visit is one that we should try regularly to achieve. Any questions or comments arising out of Richard's lovely visit? I have to say, if you haven't been to Rothbury, try and get there. It's great. But we've all been to Hexham, and you went again, Katie?
Yes, I did. And just picking up on your earlier point, Marion and I are now making sure we always get 2 for the price of 1 when we go around a walkabout now, particularly teams who perhaps don't get the coverage and not in the limelight as well. And it's really useful to do that. Hexham was just as brilliant as ever, great facilities, the staff are also engaging, such a family feel in Hexham, so it was lovely to see. Lovely to see and lovely to hear what they had to say. We went round the second phase development just as just a few weeks before it was opened, and it was really stunning, so great to see. I suppose just picking up on some of the concerns that came through, obviously the consultations were still going on with staff at that time, so they were concerned about disruption and relocation, but that has now been taken forward. We had a really good discussion with the community care team where, going back in some ways to what Richard was just saying, the distance that they have to travel and the number of patients that they have to see means it is very, very difficult to complete their rota on time. And they were very relaxed about not claiming for the extra hours that they work because it's just part of the norm. So it's sort of picking up on ensuring that they do claim for the hours that they do work. They were also a little concerned about the pool cars that were available, but again, we've picked up on that to ensure that's okay. And in particular, the hospital discharge. So there's too long a time or the right information isn't provided to community care, and the need to pick up on that as well. So those are the main points coming in.
Thank you. It sounds like particularly that last one is one we just need to dig further into, not necessarily now, but in due course. We've reflected it also from Governor views in NSA. Any points arising? Anybody wants to raise? Another successful visit then. Let's, here in due course, let's get some reassurance on the discharge process in Hexham. I think we already know that the consultation process has gone further, but it is a risky time for staff morale over the next 12 months, so I know Marion will keep us up to date with that. Okay? That's great. Thank you very much indeed, all the colleagues that have done the walkabouts. We're into the items for escalation, which means although it's quite a lot of paper, it tends to be only some areas, because all of these have been well masticated elsewhere. So first of all, we've got the nursing and midwifery staffing assurance report for August. Marion?
Yeah, I know that you'll all got a chance to read it. So the key things I wanted to bring up, and this is really from the August report, that being the most recent one. Vacancies are on track. We have in August, we had a very high attendance in ED, as you know, but you know the teams worked very well through that, as they do all the time. Just making sure that they were safe staffing and working very much with the multidisciplinary teams. The one thing I did want to flag, and it's something that Jeremy has flagged too, are the eating disorders, the increase in them, and also mental health patients. And Jeremy has a meeting this afternoon specifically about all of that. But the teams there themselves, particularly in the ward, they have done a fantastic job looking after these patients, and they are not trained in the way that we would want them to be. Hence, that's why it's a specialist area. But we are working through that to see if there's anything further that we can do. And I also wanted to raise about maternity. They have had a very busy period. We usually have an average of about 275 births. July we had 351, and in August we have had 322. We're doing a lot of work, as I said earlier, we're doing a lot of work with that, because we're finding that we are getting patients transferred often at the last minute that are booked into another area, and then they come to us because we have got very good facilities. And we're just working through that, and that was one of the main things I was talking to Jenna about yesterday, because we know that we get some from all areas, but we do get a portion from Newcastle, and I know that they are reopening their maternity unit, sort of maternity-led midwifery unit. I think it's December, Bijou. If it's not earlier than that, but certainly December. So I do think, and just to reassure Margaret as well, I do think that that will change a bit. It won't change overnight, but I know with Jim being there, with Jenna being there, we know the system that we did here and continue to do. I think that might level out a wee bit, and so that's just to flag that. And that's really probably all I wanted to say, apart from at the meeting that I was in Leeds yesterday, as I said before, there was a lot about corridor care.
About?
Corridor care.
Corridor care.
And it is going to be reported, at SQ&I, Marcus and the team, but not just Marcus, but others, but Marcus because it's generally within medicine. It's everybody's business, and we will report that. And I was able to say very clearly to them yesterday, we already report it on our SITMEC. So it's just something that I wanted to flag, but we will bring that next time.
Thank you. Anyone want to come in? Can I just ask one question? There is a reference to culture on wards 23, 24.
Yep. Again, Joe and the team with Polish Language, we are doing a lot of work in culture. And
what does that mean, I'm sorry?
Sorry?
What does it mean? What are the cultural concerns?
Cultural concerns, respect, values, how we treat people, but more probably how we treat each other.
Okay.
So we're doing a bit of work in the background with that. All the work that we're doing in theatre. So it's variations on a theme, and the best bit for me is that it's starting to come up and it's being reported, and that's the best bit of it. We don't want it to happen, we want to try and reduce it as much as possible, but we are working very closely with HR, Polish Landron and the team to try and reduce that as much as possible.
Thank you. So are we happy to receive the report? The wobbly bits for the future we need to keep our eye on: eating disorders, mental health concerns, corridor care and the cultural concerns, I think are the ones that potential future in Wales. Thank you. Then straight on, still you, Marion, the AHP Staffing Assurance Report.
Yes, I have. So again, we're still working through this and just trying to get this dashboard, as everybody would like it. And I know Margaret is very keen for this and very helpfully working with us. You can see that the registered, the REHP for the registered HPs, that has fallen this month. We're doing a lot of work again with the occupational therapy in-house apprentices. That's already started, and that's a new thing we're doing, and we're quite sort of trailblazing, I think. Everything else is really fairly straightforward. We just need to keep an eye on the turnover rate and make sure that we are trying to find out before anybody does decide to move on why they're not happy. A lot of them move on because they've got an opportunity, but we need to make sure it's not because we're not doing something that we can encourage them to stay. Obviously, we're going to look and see, we've got our celebration as in October when we're all celebrating together. I know that the community one did their one yesterday, and the EAPs are certainly doing quite a lot in that, and I think that will be very nice for everybody to come and see.
Great. Margaret.
Just to say, Marion, it's great to see the dashboards really is sharpening up.
It is.
It's thank you to you and colleagues. Again, it is a national issue with ODP. We're seeing an increased turnover, we're seeing an increased sickness, and this is national. We need to know that, but it'd be really good to understand how do we keep that particular workforce. And then the other area was, and you did mention OT.
Yeah.
We seem to be seeing more movement in OT, and that seems a bit strange to me. And again, maybe it's a deep dive later in the year to try and understand that, but it's both those areas. One I absolutely understand, the other I'm not so sure.
So two things for that.
Yeah.
Definitely about the OTs, and that's why we're trying in-house to see if we can do something differently. Also working with the council side of things. Definitely with ODPs. We have got some starting this month and next. I can't remember offhand how many it is, but I think it's 7. So that will improve, but very happy to do a deep dive into that because it is pivotal to the workings of our hospital.
Good. Corporate Safety and Quality Report, Chris? Again, this has been chewed over in several places, and some of it earlier on with Bijou's performance report.
Sure. So I think overall in August we can see a set of strong performance measures there. I think it's fair to say that we've got good processes and control those processes to deliver performance month on month. In terms of just a couple of the measures I'd just like to highlight, the first one being the 4-hour standard in the ED. We're at 94%, which was higher than in recent months. The 28-day fast diagnosis, again, really strong performance, 84.7% in that. We've seen a reduction in 52-week waits, which we're keen to carry on seeing month on month. In terms of kind of areas of focus of operational managers over the next month and following period, it's the 65-week measure to make sure we have 0 patients waiting over 65 weeks on referral to treatment. We're going to deliver that in September. We need to make sure we deliver that month on month, which is one of the key requests from NHS England. We've touched on the 62-day cancer performance, so I won't dwell on that. And the other area, just point the committee of the board to, is around complaints and making sure that we complete and return complaints to the complainant within the agreed time frame. So we're a little bit off on that, but with a lot of work, a lot of changes to processes, in training of staff to make sure that we can start delivering on that.
And you're pretty confident we'll get back to the target sheet within?
We will get back to that.
We will, he says. That's good.
We will, because we have to, because if you think about we've taken the time to complain and write to us, it's only right that we actually get back in that agreed time frame. So I think the key measure that we have to achieve.
Very good. Any questions or comments to Chris? No. Thank you. Paul, Finance.
Yes, this was discussed in detail at the Finance Committee on Monday. Just to confirm, we remain on target to hit our agreed surplus position for this year of 13 million. We have indicated to the ICB that there is pressure on the CDL limit, and we are working with others to see if we can mitigate the impact of that potential overspending as going down.
Thank you, Paul. Any questions or comments coming up from the board? Thank you very much indeed. The agenda for next meeting we've got in draft in front of us. I'm sure it'll change by then. This is always the work of fiction stage, I think. Review of the meeting? Comments? How's it gone? Good? All happy?
Yep.
Anything you wish you'd had a chance to say or remember? No? Very good. In which case, I haven't been given notice of any questions from the public, so let's take ourselves a little bit of a lunch break. The private hall starts in 40 minutes. We've got a slightly extended lunch break, let's go. Thank you very much. Thank you, Kat, for joining us. I hope you found it interesting. And thank you, Robert, also for joining. I hope you also found it really interesting.
Thank you very much.
Bye now.